take-home message: if any patient, elderly patient, complains of any painless gradual enlarging orbital mass, we should always suspect lymphoma, and histopathology should be performed along with IHC to confirm it and to rule out other aggressive subtypes. And again, EBRT is curative with 95% remission rate, and it avoids unnecessary surgery and chemotherapy. Thank you. These are my references.
Thank you, Kiran. It's wonderful result and very beautifully presented. And in your case, why have you considered EBRT? What make you thought that EBRT should be the first line of management?
Sir, because first of all, as the age of the patient, the lady was very old, around 100 years age, and coming from a low socioeconomic status. And again, as we can see, the mass is very well localized inside the orbit. Not there is no bone erosion, no other involvement, no systemic involvement was there. So that case, I think EBRT has better outcome.
Excellent. And what about any side effect EBRT with EBRT?
No such side effect was there.
The vision was okay?
Yes, as it was cataractus, the vision did not improve, but later on that lady underwent cataract surgery and the vision was good.
Very nice, very nice.
Very nice presentation, Dr. Kiran. Just one thing, you mentioned the patient had cataract, right, in
Yes.
that eye, along with a large lesion.
Yes.
Possibly the vision loss in that eye was due to an optic nerve compression, because that's a huge lesion which has been sitting there for a very long time, I'm guessing.
Yes.
So, anyways, very good outcomes.
Yes.
Amazing outcomes.
Sir, first of all, seeing about the pupillary reaction was there. It was
Okay.
well reactive, and also there was initially we could not elicit the extraocular muscle movement, but when the mass gradually decreased, it was there. There was no neurological deficit.
Okay.
So.
So you're able to see, like, was there any gain in vision afterwards?
Yes, sir. Improvement vision was there.
Okay, nice.
Okay, thank you. So we move on to the next speaker. We have Dr. Banka Megha. Next speaker, Banka Megha. Is it available?
Banka Megha, slides available?
Next, Dr. Gunjan Shah. So absent, Banka Megha, Gunjan Shah is absent. What about Dr. Kajal Bansal?
Kanjan Bansal PPT.
Recorded PPT is there? Kajal Bansal, can you please play the recorded PPT if it's there?
Or metastatic. A 58-year-old female presented with complaint of blurred vision in left eye since 1 month and headache since 1 month. She said she had left-sided body pain and severe backache. On further probing, she had some weight loss. Her visual acuity in right eye was 6/9 and in left eye was 6/36. Anterior segment examination of both eyes were within normal limits. There were cortical cataract in both eyes. Right eye posterior segment examination was normal, and in the left eye media was clear. Disc was normal, and there was dome-like elevated mass around 8 disc diameter of varying color along the superior temporal arcade with vessels overlying it. So we had differentials of tubercular granuloma, choroidal abscess, choroidal metastasis, or it could be amelanotic choroidal melanoma. Age, history, and clinical picture was in favor of tubercular granuloma and metastasis. B scan, there was choroidal thickening, well-defined homogeneous choroidal mass with high surface reflectivity and low to medium internal reflectivity. So B scan was also in favor of metastasis. Patient was advised to review with oncologist, but she didn't come for follow-up. She turned up after 6 days with worsening of her symptoms. Her visual acuity dropped to 6/60. There was whitish yellow choroidal lesion, subretinal hemorrhage surrounding subretinal fluid, and inferior exudative RD in the periphery. OCT was done through the lesion. There was subretinal hyperreflective mass coming from the lesion. This OCT was again in favor of granuloma, abscess, and metastasis. Acute worsening of symptoms and all the other findings were against the amelanotic melanoma. Patient was advised battery of investigation and oncology evaluation. but she didn't come for follow up. After 15 days, she came with the reports. Based on these reports, tuberculogranuloma was excluded, but her AC levels were elevated and there were mediastinal lymph nodes. So, can it be sarcoid? Clinically, no, as it was a very huge lesion. But the oncologist was not keen on metastasis because there were no systemic evidence of metastasis. There was significant increase in the size of the lesion. On the B scan also significant increase in the size of the lesion was noted. So it is a case of left eye choroidal mass which could be infective or metastatic. Patient was advised to undergo biopsy which was suggestive of malignant cells from the adenocarcinoma. Then the patient underwent PET scan which was suggestive of gastric adenocarcinoma as the primary malignant neoplasm, and there were metastases in her whole body. So it is a case of choroidal metastasis which was secondary to gastric carcinoma without any evidence of systemic features. Oncologist was not keen on metastatic evaluation. HRCT and serum ACE levels were misleading in this case, and biopsy has to be done due to this uncertainty. Choroidal metastasis may be the initial presentation of underlying malignancy. Biopsy can be considered if systemic investigations are not suggestive of malignancy, but we should rely on our clinical examination skills rather than the investigations alone. Due to its abundant vascular supply, choroid is the most common ocular site of metastasis. It usually go undetected, and we should have high index of suspicion in elderly cases to consider the diagnosis.
Yes, so do we have the next speaker? Your name, please. No, okay. So you can take on the slides. It's fine, fine. Your name is here. Yeah. Okay. So next speaker is Dr. Najwa. She will be speaking on nasal carcinoma presenting with orbital apex syndrome.
Okay. A very warm good morning. My topic is sinonasal carcinoma presenting with orbital apex syndrome. Sinonasal carcinoma is rare but aggressive malignancy arising from the nasal cavity in paranasal sinus, and it accounts for 3% of head and neck tumors. The most common pathology associated with sinonasal cancer is squamous cell carcinoma. This cancer is often diagnosed very late as it remains asymptomatic until the tumor invades or approaches critical areas such as skull base, nerves, orbit, or palate. Coming to the case, a 56-year-old male patient, smoker, presented with complaints of gradual progressive painless loss of vision and pain in right eye for 3 months. There was a protrusion was seen on the right side of the nose. Visual acuity of right eye was no pale, left eye 624 partial. These are the salient findings on examination. In right eye, there was an eccentric proptosis, an amaurotic pupil, extraocular movements markedly reduced in all positions of gaze. Corneal sensation and facial sensation over V1, V2 area were reduced in right eye. In left eye anterior segment, there was a grade 2 nuclear sclerosis, and otherwise it was within the normal limits. This is the clinical photographs showing limited extraocular movements in the right eye, and the MRI shows soft tissue lesions from the maxillary sinus extending to the orbital apex, encasing the optic nerve. A biopsy was done, and the histopathology report showed sinonasal non-keratinizing invasive squamous cell carcinoma, which is cylindrical cell carcinoma or Schneiderian carcinoma. Treatment: patient was started on chemoradiotherapy, but the patient passed away after 3 months of treatment. What is unique about the case? Sinonasal carcinoma is presenting with orbital apex syndrome is rare, and the histopathology of cylindrical cell carcinoma or Schneiderian carcinoma or transitional cell carcinoma is a rare variant of squamous cell carcinoma. Clinical implications: this case highlights the challenges in diagnosing and managing sinonasal carcinoma and underscores the importance of multidisciplinary care for optical outcomes. Early diagnosis and interventions are crucial in preventing complications and achieving favorable outcomes in patients with aggressive malignancy. The take-home message is orbital squamous cell carcinoma often occur because of secondary spread, including direct invasion of the nasopharynx, nasal cavity, or paranasal sinuses, or hematogenous dissemination. A prompt diagnosis and multidisciplinary treatment approaches are crucial. Treatment options for orbital squamous cell carcinoma involve single modality or multimodality approaches such as chemotherapy, radiation, or surgical resection. Thank you.
Nice presentation, Dr. Nazwa.
Thank you, sir.
The thing is that usually sinonasal carcinomas or any form of tumors, there is always a potential of that presenting as an orbital apex. Okay, it's not
Yes.
very rare,
Yes.
but it can present because the way it reaches for the orbit from the inferior, as in from the maxillary sinus per se,
Yes, sir.
there's always potential. It goes and moves towards the posterior aspect,
Yes, sir.
reaching the apex very soon.
Okay,
So,
sir.
anyways, it was a very nice presentation.
Thank you, sir.
We can move on to the next presenter. Your name? Okay. We have with us Dr. Banka Megha. She will be talking about OSSN.
Yeah.
Okay.
Imagine a farmer comes to you with a farming injury in your busy OPD and you treat it as a simple corneal ulcer, missing something far more sinister creeping right next to it. Good morning, class. I'm Dr. Bankamegha Ajay, and today we will learn about how to never miss an ocular surface squamous neoplasia. OSSN is the most common neoplasia of the ocular surface. It is a limbal stem cell disease and a clinical continuum of precancerous to cancerous epithelial lesions of the conjunctiva and cornea. With a diverse list of incriminating associations, it is usually unilateral. When bilateral, it is associated with HIV, immunosuppression, xeroderma pigmentosa, or palmoplantar keratoderma. OSSN, a disease of the conjunctiva, cornea, or both together, can present to us in one of its many forms. With this background of OSSN, let us approach this case of a 74-year-old farmer who presented with pain, redness, foreign body sensation in his left eye following a farming injury 1 month ago. He was treated with topical medications for the corneal ulcer at a nearby clinic. With no improvement and further deteriorating visual acuity, he was referred to our center as a suspected case of OSSN. On a closer look, we appreciate a brown corneal opacity with feathery margins, stromal hydration. Overhanging the temporal edge of the corneal opacity was a fleshy, gelatinous conjunctival elevation with multiple petechiae. The junction of the two lesions stained positively for rose Bengal. To further assess the inflamed, thickened conjunctival lesion, we checked for the 3 other hallmark signs of OSSN and noted surface keratin, increased intrinsic vascularity with prominent feeder vessels, and episcleral and corneal fixity. A corneal scraping of the ulcer confirmed dimetaceous fungal corneal ulcer, and there was significant clinical improvement within 3 weeks of topical medications. After clearance from the cornea consultant, we proceeded with complete surgical excision of OSSN with 4 mm clinically clear margins, alcohol-assisted keratoepitheliectomy with supplemental cryotherapy to bare sclera and the conjunctival edge, followed by careful ocular surface reconstruction with amniotic membrane graft. Don't be deceived by this beautifully healed ocular surface with no evident residual tumor or recurrence, as histopathology is king. It reported a positive base and adjuvant therapy was planned in the form of secondary plaque brachytherapy. At 2 weeks post-plaque, our humble farmer is back at the farm with a visual acuity of 6'9". While OSSN is notorious to present as one of its many masquerades, especially corneal ulcer, OSSN coexisting with corneal ulcer is a rather rare case scenario, and literature recognizes it as a challenge with poor prognosis. However, we followed a methodical approach to control the active fungal ulcer, then proceeded with surgical excision of OSSN and further treated stromal invasion with secondary plaque brachytherapy. And at 6 months post-op, our patient is tumor-free. Be it an OSSN staring in your face, a masquerade, or coexisting pathologies, the holy grail to identify OSSN will never fail you. Once diagnosed, always assess depth using ASOCT or UBM, and when in doubt, always get an MRI for orbital extension. The gold standard treatment for OSSN has evolved from wide margin surgical excision to topical immunotherapy and plaque brachytherapy. Now, if you've slept for the last 3 minutes, here's your chance at redemption. OSSN is strictly a clinical term, not to be used for histopathology reporting to prevent misinterpretation. Always check for abnormally thickened limbal conjunctiva with all hallmarks of OSSN in its mimics. Never forget notes. When two pathologies coexist, always prioritize aggressive tumor control before any other surgical intervention to prevent intraocular or orbital spread, and always respect oncological principles. Thank you.
Very nice presentation, Dr. Banka.
Thank you, sir.
So in your case, would you like to consider for primary plaque brachytherapy after healing of this infection, or uh, why is surgical excision followed by the plug brachytherapy? Which one you want to consider?
We would go for primary plaque brachytherapy in case we are sure about the base positivity with fixity. In this case,
But
episcleral fixity.
clinically, you have
Yes,
said that
exactly.
the
Yes,
scleral
sir.
fixity was there.
Yeah, episcleral actually it moved over the conjunctival part of it moved, but we noted stromal invasion intraoperatively. So we thought we could just wait for histopathology confirmation and then we could go ahead with secondary plaque brachytherapy. But in either cases, primary plaque brachytherapy is just as good if we are sure about our clinical judgment.
Thank you.
Thank you, sir.
So do we have the next speaker, or this is recorded one? Any physical? Yes. Who is that one? So next is the recorded PPT will be presented by.
Good morning, everyone.
Can we have
I
the
am Dr.
PPT?
Zuba Tasneem from JNMCH. The title of my case is Beneath
Dr.
the
Zuba,
Surface,
right,
Uncovering the
okay.
Hidden. So I'm very sorry that I could not make it there,
Dr.
but
Zuba?
here's my video presentation on OSSN. Ocular surface squamous neoplasia is a spectrum of eye surface tumors that ranges from mild dysplasia to invasive squamous cell carcinoma, typically affecting the conjunctiva and cornea. The stem cell theory says that origin is from limbal transition zone. The risk factors include UV light exposure, HPV, infection, immunosuppression states, and xeroderma pigmentosa. The patient presented with complaint of diminution of vision in left eye. He was a 48 years old male and a white mass for 5 years. There is history of diabetes mellitus for 23 years and post-COVID-19 mucormycosis, for which he underwent bilateral maxillectomy 3 years ago. The vision in right eye was 6/6 and left eye was finger counting at half meter. NCT was 13 mmHg and unrecordable in the other eye. Conjunctiva was normal in both eye. Cornea was clear in right eye, and whereas left eye showed this. As we can see in the picture, there is this grayish white horizontal opaque band of 2 into 7 mm in size, which is spanning the pupillary area. It has an irregular surface. Anterior chamber was normal and coid. Pupillary reaction was normal size, normal reaction, and in left eye it was not visualized. Iris was normal color and pattern in both eyes, and lens was IMSC in both eyes. Fundus in right eye was within normal limit, and left eye showed hazy media with central fundus within normal limit. Impression cytology revealed full thickness squamous metaplastic cells with anisonucleosis. So we planned the patient for excision of mass with amniotic membrane grafting. Histopathology revealed non-keratinized stratified squamous epithelium with moderate to severe focal dysplasia and stroma, loose fibrocollagenous tissue with areas of hemorrhages and congested vessels. There was no breach in basement membrane, and they came to a diagnosis of OSSN SYN3. Patient was then advised an postoperative period as topical mitomycin C drops 0.04% for 3 cycles, 2 weeks on and 2 weeks off, with antibiotic and steroid. Postoperatively, patient gained a vision of 6/60 with a slight nebulocorneal haze at the operated site and a nasal fleshy mass. So the difference in this case was that it is a rare presentation of OSSN, which as we saw that it has occurred post mucormycosis, and when the patient underwent maxillectomy, it occurred after that, which is an unusual background for OSSN. And the normal OSSN lesions is usually nodular or gelatinous, whereas in this case it was horizontal grayish white lesion. In follow-up, there was no signs of recurrence. The case highlights early diagnosis and prompt intervention of a neoplastic lesion prior to sequelae. Clinical implication says that recurrence rate of OSSN after surgical excision can occur in about half of cases for 10 years. Rate of recurrence is substantially higher in setting with positive surgical margin. Invasive squamous cell carcinoma is also an entity which involves orbit, globe, and can invade to sclera. Thank you.
Next speaker through online recorded is Dr. Shruti Dhinsi.
Good morning, all. Myself, Dr. Shruti, PG from KMCRI, Hubli, Karnataka. Have you ever seen a mysterious huge orbital mass? Well, I would like to decode as such a rare and atypical case of pleomorphic adenoma of the lacrimal gland. Lacrimal gland tumors are relatively rare entities compared to the inflammatory disorders of the lacrimal gland. Most common types of lacrimal gland tumors are lymphoma, benign pleomorphic adenoma, and adenoid cystic carcinoma. It is essential to recognize and manage these conditions appropriately, as a delayed or misdiagnosis can have a dire consequences on the patient. A 77 years old female resident of Sangli, Maharashtra presented with a mass on the left side of the face since 10 to 15 years. Mass was small initially, which has gradually progressed to the present size. There was no history of the pain. No history of any other swelling or mass all over the body, no significant history of trauma, systemic illness, or the surgery, no significant family history. On examination, right eye, anterior and the posterior segment examination was normal. On the left eye, orbital structures was not visible due to the presence of solitary bosselated irregular exophytic mass in the orbital area, measuring approximately 12 into 10 into 8 centimeter. It was non-tender, firm to hardened consistency and immobile in the nature, extending superiorly over the frontal head and medially over the root of the nose, laterally over the lateral orbital rim and temporal fossa, and inferiorly over the maxillary region. Left orbital contents was displaced inferiorly with the visible eyelids and few eyelashes only, as seen in the image 3. Radiological reports enclosed heterogeneously enhancing mass lesion with the probable epicenter as left orbit with extension into skin and subcutaneous tissue anteriorly, frontal sinus and intracranial extension superiorly, posteriorly involving the sphenoid sinus, feature suggestive of a malignant mass. Following which an incisional biopsy was done and histopathological report showed epithelial and stromal component in the tumor with the round cuboidal cells arranged in the sheets and clusters and in clots with the basophilic nuclei and a moderate cytoplasm, features suggestive of pleomorphic adenoma of the lacrimal gland. Multidisciplinary approach was done and the oncosurgeon has operated. Left orbital exentration with the debulking surgery was done. Circumferential skin incision was taken around the tumor except for the biopsied area and then remnant ocular structures. Gentle dissection with the monopolar cautery was done to separate the tumor from the orbital wall. Optic nerve was identified, clamped and cut, and the tumor was removed in toto. And the orbital cavity was filled with the hemostat surgical and closed with frontal flap. Procedure went uneventful. Post-operatively, patient's GCS was very poor. On third day, patient had stroke attack and collapsed. And patient could not be revived with the poor GCS, and the patient succumbed on the fifth post-op day. Histopathological report confirmed pleomorphic adenoma of the lacrimal gland. What is unique in my case is this patient had a massive long-standing tumor with the bony erosions and involvement of the sinus and nasolacrimal apparatus. Biopsy, which is typically avoided, was necessary in this case due to the malignant radiological features, and histopathology confirmed the pleomorphic adenoma in spite of the spread to the surrounding structures. And multidisciplinary approach was done, and orbital exentration with tumor debulking surgery was done. Clinical implication: rapid growth, pain, or inflammatory conditions may mimic the malignancy. It has an imaging complexity, and adherence of this masses to the adjacent structures increases the malignancy risk. So, incomplete excision may cause an recurrence. Surgical planning requires a multidisciplinary team. Take home message: pleomorphic adenoma can present really in an atypical manner, like the pain, rapid growth, or bony erosion, which mimics the malignancy. CT and MRI is crucial, but biopsy may be needed, and the atypical cases may have a malignant transformation. Complete excision with an intact capsule prevents the recurrence in such cases, and post-operatively long-term follow-up is needed to look for the recurrence and malignancy. Thank you, one and all, for giving me this great opportunity. I have nil financial interest, no conflict of interest.
Okay, so do we have any more speaker? Dr. Deepika Beraka, Dr. Preksha, Dr. Gunjan. So all are absent. Okay. So with that we come to the end of this session, and the next session can take up subsequently.